this over.
Well, good afternoon. I'd like to welcome everyone back to their seats, and especially welcome Senators Bates and Steiner-Hayward for joining us, and we're really excited to have you with us today. We're formally reconvened in public session for the Oregon Medical Board full board meeting. I want to say we're glad to have you with us, and I recognize that we have an important relationship with the legislature. The Oregon Medical Board, and especially this group in particular, are proud to maintain our primary vision and mission to protect the safety of Oregonians, but at the same time, we want to communicate with you that we have a powerful theme to explore every opportunity for remediation. We like to view our role as first and foremost looking after the safety and well-being of Oregonians, but also finding every opportunity to bring practitioners back into safe and meaningful practice and help them to do that and support. And we're trying to reach to the community with a theme of positive nature in that regard. And we're very interested to hear what you have to say, and also would like to establish a strong relationship with you and the rest of the legislature in transparency and partnership as we move forward with these themes in mind. Thank you for joining us today.
Thank you for having us.
Thank you for inviting us. It's interesting to be here in this new role. I've had the opportunity to interact with several of you other times in other contexts, and it's a change for me to be here in this role as a legislator. Dr. Williamson, you did a good job of reminding us of what the mission is of the board, and I had it pulled up here, and here we go. And I think remembering that mission and also remembering that the part about promoting access to quality care is really important as part of our conversation today. We're here both as legislators and physicians because we've been hearing more noise than we would expect, which is to say when you hear a few isolated grumbles, that's one thing, but when you're starting to see a pattern, then one becomes concerned. And the pattern that we're seeing and that we're hearing is of a board that may well have the intentions that you describe, and I hope that that is the intention of the board, but is in some cases, and it's hard to put a number on it, acting in ways that aren't congruent with Dr. Williamson's description, which is to say that we're seeing situations where process is not transparent at all. We have been hearing concerns about investigators who don't disclose who they are, or when they are having conversations, do not warn physicians or their staff members that what they're saying can be used as part of the investigation prior to having the conversation. We're hearing about physicians who are basically being told by counsel, go in, nod your head, say yes, sir, yes, ma'am, and don't deny anything because otherwise you'll be seen as arrogant. We're seeing physicians who have had one bad outcome and it's been turned into something that ruins their careers. And obviously, there are lots and lots of investigations that happen annually, and as I said, we don't have a numerator and a denominator here, so I can't tell you a percentage. But our real concern at this point, or real concerns, are the following. First, that there seems to be a sense of arbitrariness and inconsistency. So some physicians who are investigated for certain kinds of problems get one kind of approach and others get something entirely different. The second is that contrary to what Dr. Williamson said, which I think is what we would all hope, which is the opportunity to rehabilitate or re-educate physicians who've made mistakes, which anybody can do, is instead being much more of a punitive approach. And there's a presumption of guilt rather than innocence. And finally, that there's a lot of lack of transparency about the process. Nobody really knows what to expect or when to expect it. And the concern that we have as legislators is that at a time when we already have a workforce shortage in the state, and it's only going to get worse with healthcare transformation and with expansion of the number of people who have health insurance, we are creating a climate in which there is fear among physicians, in which our state is getting a reputation, and I certainly have been hearing this from my colleagues around the state, that this isn't a comfortable place to practice, that the relationship with the board is a dangerous one. And I use that word carefully. I mean, that's not a word I use lightly. And finally, that people are afraid to bring to the board's attention real concerns because they think that the physician will be treated in such a way that won't allow for rehabilitation and reentry into a safe practice, but rather will force that person out and cause really significant psychological and economic distress to people. So we're very concerned about that, and we do want to have a productive, transparent, collaborative relationship both between the legislature and the board, and between the board and physicians, physician assistants, and podiatrists in the state, because and acupuncturists, which the board also obviously covers, because this should be about collaboration. This should be about promoting a culture of patient safety. And just as we're looking to reform our medical liability system in ways that promote transparency, promote early disclosure, promote system change to prevent future errors, that's exactly what we would be hoping for from the relationship between the medical community and the board. And that's not what we're hearing now. So we appreciate the opportunity to come talk with you and start to figure out how we move forward. Dr. Bates is going to say a few things, and then we're going to be eager to have some conversation with you.
Thank you.
First of all, thanks for having us here today and taking the time to meet with us. I'm not going to offer much more than what Elizabeth has said, but I'm going to add a few things to it. First and foremost, I'm here as a senator, not as a physician, and I never want to be here as a physician. Let's make that clear, okay? So, two hats, two different worlds. They often collide. And we are looking forward to having a dialogue today. I really want to start a dialogue and hear both sides of the story and get a clear understanding of how the board is functioning and what's happening. I've had complaints about the board for 15, 20 years, and maybe longer than that. And I check into those things, especially in the last 12 years since I've been. I was a medical director for a while. I look into them, and then as a representative senator, I look into them. And I found the vast majority of them, quite frankly, were unfounded. These were disgruntled physicians who they felt the board had treated them unfairly, and I disagreed that the board was spot on. The last 3 or 4 years, I started getting complaints, and more complaints than normal, and I started checking into them, and most of them were founded, but a couple of them I kind of scratched my head about. I couldn't quite understand it. And usually I got them from physicians in my immediate area, but lately I've been getting them from physicians across the state that areas I never go to or know much about, and it makes it a little more difficult. And admittedly, most of them I still think are founded. I think you're doing the right thing. But there seems to be more and more cases where I kind of scratch my head, not quite understanding what the board's position was, or how you approached the problem, or how you dealt with the problem. And I think it really kind of dated back to one particular episode in which a surgeon in the state was sort of working under the radar because we couldn't see his medical malpractice issues because he was, at that time, working for organizations that did not have to report malpractice to the board because they were self-insured. We changed the law on that and fixed it. I think Kathleen remembers that little battle we had together. I think we did the right thing, Kathleen. I hope you agree. But after that happened, things seemed to start changing. I think the board became very, very concerned. And some of you may not have been here at that time. I'm not sure what the board turnover has been like. But it was something that kind of bounced back to the board like it was the board's fault for letting the surgeon go on and on and on. And when he went to Australia, was immediately uncovered and censored and had his license stripped. But you had no way of knowing that. So that problem's been fixed. But I just sense that since that time, there's been this different kind of feeling that we have to really be strict and careful, and we have to get everybody. And when I hear that when physicians come before you, it's sort of you're guilty until proven innocent. You will listen to what we have to tell you to do. It's not open. There's no respect. There's not an opportunity to try to explain what's going on. And most importantly, for these cases I'm most concerned about, instead of saying, I didn't know that was an issue, but I understand it now, and I'll make those changes. And I'll give you an example of that so I could be clearer if I could. I just came back from a 5 days of continuing medical education, and the theme of it, and this huge, it's 5,000 physicians there, was about opiates and the incredible amount of opiates being written and the low control on it. And people are actually going to jail for this. And they laid out about 3 things you should always do when you see an opiate patient, which would take you probably 45 minutes per patient. And you should do it every 3 months or initially every week when you're first seeing them. Doing a check to make sure they're not getting anything anywhere else through your electronic system, having a contract. There's a checkoff list of 10 things you should look for in each of these patients, and complete look at their function and pain levels. All these things have to be written down and documented in the chart. And I would guess that if you went out and talked to physicians who have maybe 10 or 15 of these patients in their practice who don't have cancer, are over 65, and asked them, are you doing all 3 of these things? They'd say, I didn't know I had to do all 3. I got a pain contract. I occasionally check the prescription monitoring program, but I don't do the 10 checkoffs. And they don't know that. And they can be brought in and censored by this board for not doing that, and they were unaware of that. And I don't think it's wrong to bring them in, but to educate them and say you've got to make a change, and we were going to check up to make that change as it happened, that's perfectly correct. But threatening their license, fining them, is a different problem. For things that they really weren't, I think, were negligent about. It was a lack of understanding and knowledge of a small part of their practice. And so people have gone through those kind of processes with you, and it always hasn't been the best they could ever hope for. Instead of an educational process, a process that allowed them to go back to their practice and improve what they're doing with patients, it was looked at as punitive. And kind of thing they think about, I think I'm going to leave the state. I'm going to get this behind me. I think I'm going to leave the state. I don't want to go through this with the board again. And they've talked to their friends in other states and asked them how it's handled. And sometimes it's the same, sometimes it's different. But of course, that's a very anecdotal. I want to give you a couple other pieces real quick, too. We are seeing more and more difficulty with boards, non-medical boards, over the same issues. So don't feel like you're alone here. I'm dealing with another board right now that came to me because of the same type of issues in a completely different field. I mean, it's a contracting board for landscapers. You're like, who the heck are they? But they are actually a board, okay? And it's very serious for these people because they can lose their ability to have a certification licensing and can lose their jobs. So there are several boards having trouble with that. We've talked to the governor's office, or I've talked to the governor's office about this. We're doing a review of the boards and commissions. We have so many boards and commissions in the state that we can't even keep track of them. We don't even have a central documentation of how many there are. So we've got board issues, and we're going to deal with them board by board by board. But we'd like to see the boards move more in the direction of patient safety or public safety first, education of the people doing the work second, but very close to number 1, and punitive action number 3. And that's I think what this dialogue is going to be, hopefully be about today. I really don't want to be here. I have better places to be right now than sitting in front of the board that regulates me as a state senator and talking to you. Trust me, I don't want to be here today. But the complaint level is risen to a level of certain physicians that makes me concerned to the point that I wanted to come have a conversation with you. And I think this is the best way to do it, is have an open dialogue. We have a responsibility for this board as senators, along with the rest of the Senate and the House and the governor. And if it was the landscapers board, as an example, I sat in front of them the same way and had a discussion. There's another board I'm going to have to do the same thing with. We had a problem with the nursing board a couple of years ago. So this is not unique to this board. But as state senators, we would like to have an opportunity to have this dialogue, have a chance to talk back and forth, not interrupt what you're doing for public safety, but ask you to start thinking about it a little tiny bit differently from the point of education, and maybe a little more discretion in dealing with some of these physicians. And that's what I think is the key word for me, is discretion. That's the same word we've used for the other boards. You know, I'll give you an example again, because I like examples. They make things concrete for me. And one of the boards I'm looking at, if you have a business card and the phone number is wrong on the business card for the board, and the board changed their phone number a year ago and didn't notify everybody, they come out the work site, they look at you, they ask for your business card, they see the number is the old number from a year ago, and you get fined $500. That's lack of discretion, okay? And they keep the fines to help support their program, which is another issue. So I try to give you some examples that may make sense to you. I'm hoping we can have a conversation here, and I'm hoping that we can move to a board that is protects the public, educates physicians, but uses some discretion. That's what I'd ask.
Great comments, and thank you. I know we're going to have a lot of board members that want to talk about this, and I'm going to give some opportunity for this conversation, which is extraordinarily valuable. First, say thank you, and I can think of a lot of things I'd like to say, and I'll keep the comment short. Other than to say that I might talk about a personal experience and why I'm here, and some of the things that I heard from my colleagues as a colleague of yours, as a physician, when I decided to join the medical board. And the first thing that I heard from another of the other clinicians is, why do you want to become a bad guy? And the answer is, I don't. One of the things that keeps me coming to work every day when it relates to the medical board is the notion that I can turn this work into a positive experience for our community. And one of the themes that I'd like to drive as a chair, a role I've taken on for the last few months, is to work tirelessly to create a positive theme, and that is with remediation and helping physicians when it's possible. And this is a difficult double hat to wear, or dual role. At the same token, we do place a higher priority on protecting people and saving lives. And we've seen some egregious cases, no doubt, where unfortunately a well-intentioned practitioner, and sometimes not so well-intentioned, has led to the deaths of several people. And we've seen egregious cases which affect us in a deep and emotional way. We try to take emotional aspects out of it and making determinations, but at the same time, we have an intense desire to try to help our colleagues when there's a chance to help them and have them back in productive practice. For a variety of reasons, one of the most important, of course, is preserving the all-important access to care in an ailing healthcare environment in Oregon in particular. And one of the most important themes in our healthcare reform models, no doubt, is making sure that we have a powerful and well-trained workforce to deliver the care that we need for Oregonians. We want to create a positive theme. We want to break free of the shackle of the concept that we might be a Gestapo organization. And this theme of transparency is one that has also been somewhat duplicitous. We know it's very important to be transparent. But we refer back to our board bulletin as almost like an obituary of physicians. And one of the most important things that we hear back from our clinicians and colleagues in the community is a sordid idea that when the board bulletin is mailed out to them, that the first thing they do is go back and look and see who they know that's on the list of people who've been in trouble. That's not the kind of theme that we like to see, nor is that the kind of message that we want to send to our community. We want to send a message to the community that we found ways to help people. And if I have to say anything that might have changed in the last few years in my more recent experience with the medical board is that our ability to support physicians has been curtailed due to resources. The loss of the PEER program that was sponsored by the Oregon Medical Association is one of the biggest examples. We would turn to that as an opportunity to help bring clinicians back into safe practice, training, and fixing specific problems that we know can be made better and safer for delivery of care. Without that, we've had to turn to outside evaluations and come up with our own method of remediating physicians. It's been more cumbersome to do that and more costly for physicians to do that. That's something we hate. We've been spending a lot of resource trying to come up with an alternate method to help physicians get back into practice without asking them to leave the state for an evaluation or ask for a mentor that's out of state to come at an expensive price to help them through major issues. I think you're right on target with regard to where we want to be with the theme of a positive relationship with our community and protecting patients, Oregonians in general, but keeping our practitioners active and practicing. We have approached every case with that theme in mind. And I also have to say that I cannot sleep at night unless I felt like that I've been extraordinarily diligent at looking at every case detail. We never want to rush through a specific complaint or a judgment about an individual practitioner because I place myself in their shoes. What is it like to sit where you're sitting? It's awful. This is one of the worst experiences a physician could ever go through. I'm very sensitive to that, and I think that one of the things that makes me feel more positive about doing this job is that I feel like I have the capacity to hopefully to change that a little bit. And when you talk about and you're describing some of the issues that you'd like to go after, I think one of them really is respect. We want to build respect in the process of interviewing our physicians and be mindful of the stress that they're going through and not take a punitive approach, but rather a constructive approach. And that's a theme that we've been fighting to get to. And I think we've been making some progress in that direction. We want to embrace this, and I think the best way to help the medical board to land these benchmarks of improvement is to hear specifics from you, and when you have complaints, we want to respond to them and make things better. And we really cannot improve as an organization without having that kind of feedback. And we need to have a direct mechanism to address those things and hear it so that we know what we need to work on, and by God, we'll do it. I mean, we have the capacity to do it, and we're interested in doing it. I'd like to ask Mr. Kopetsky to make some comments. Is this a good time for you to talk?
I'm taking note, but sure. Thank you. Senator Baines, Senator Hayward, thank you very much for coming. I'd like to say as a public member, I've been on this board since 2010. Before that, I was chairman of the Bottle Bill Task Force, which helped in the recycling bill that came about in 2011, I believe. And before that, I was also chairman of the Oregon Government Standards and Practices Commission, which is now called the Ethics Commission. So I've had amount of experience sitting on boards and stuff. And I want to say that of all the boards that I've ever been on, from community colleges to juvenile health services and stuff, this is the most hard-working board I've ever seen. These people here are dedicated to everything that they do. And the 2-day meeting that we've had here, it is not hours of preparation, it is days for the people sitting at this table, and it's months of preparation for the people that are sitting back there, and they do a tremendous job. The time that I've been on here, I've never seen an organization that is so dedicated. For one, is protecting the public that this board does, and two, is to help in getting physicians that are impaired back into practice. They do everything they can to from retraining to whatever help that is needed to get these people back into practice, and that's a big priority here. The number one priority, of course, is patient safety of Oregonians. And even the decisions that we make, every case that is being reviewed. I sit on the AAC committee and the investigative committee as well. Every one of those cases is due diligently reviewed. And it doesn't matter if it's 8 o'clock in the morning when everybody is fresh, or 6:30 at night when everybody is really tired. All those cases are diligently reviewed. And I want to say that there is a consistency in what happens in these cases. There isn't personal prejudice when it comes to the handling of these cases. It is on the facts, what has happened, and what needs to be done. And the other thing that it's also is we understand that in some of the parts of the state, when a decision is made to maybe take a physician out of practice, we look at what the effects that's going to be on the community. So that's an important part of that, and we do everything we can to keep those people back in practice if we can. So.
Girard.
So, Senators, I'm Don Girard. I really need to make this comment. Please bear with me. I'm astounded by what you said. And let me try to give you a little background. I spent my whole career at OHSU. I'm a general internist. Elizabeth knows that. I spent my last 20 years as the Associate Dean for Graduate Medical Education, and the rest of my career working with residents primarily, but not exclusively, in internal medicine. My entire career there has been spent, in my opinion, interested in and committed to physician wellness. In my opinion, physicians do not typically either get well or stay well. And a decade ago, we started a wellness program at the school to try to help doctors do both. And we, I think, have succeeded. I came on this board reluctant because I spent almost 10 years in the supervisory council, the Health Professionals Program, and I reported as the chair of that body to this board every 3 months. And it was with trepidation and with propranolol on board that I shared our findings with this board. I came on this board with the same concern. And I came because I thought, just as Dr. Williamson has said, that we have to be respected, and we have to be part of a solution rather than a problem. And that's the way I have spent my entire career at OHSU, with remediation, with helping with the goal of physician success. And that was my attitude on this board. I will tell you, in my 4.5 years here now, it's been exactly that case. I'm stunned by your comments, but please, just one more of mine. I have found around this room individuals who are bright, informed, and committed, certainly to the safety of patients, to our public, but also to the rehabilitation, the successful replacement of our health professionals back into their practice. I've been so happily, this experience has been so positive for me as a good, positive theme. I can't begin to describe it. So what you're bringing forward, I'm not going to challenge you with where the information came from, but is stunning to me. I mean, just stunning, because it is not at any level been my experience.
Before we go to, would you like to make a comment? We're setting a stage for a conversation, and instead you're getting a barrage from us.
No, that's okay. I did want to just pick up. I'm actually trying to take notes, because what I like to do in these situations is you can have a dialogue, you walk out, you go, did you remember anything that was said? No. Where are we going next? I don't know. Dr. Williamson, you mentioned a peer, OMA had a peer what?
It's called a peer program. This is a program set up to...
Peer program?
That's right. A program that was in, and you can hear more about that later offline, but a program that was set to allow physicians to address or have help with specific problems that would allow them to get back into meaningful and safe practice, oftentimes involve a mentor after an initial evaluation. We don't have that structure anymore. We'd like to be able to sponsor something like that at the level of the medical board, but we don't have the resource to do that. So instead, we're asking physicians to go off to their evaluations with specific plans for remediation to come back from those evaluations, and then it's up to us to help that clinician find the resources to do it. And it's expensive and sometimes not obtainable. That's a fundamentally bad issue that needs some help.
Can I just clarify one thing about that? Was that the one that went away in 2009 as a result of the there was a bill that went through the legislature in 2009, I think. It was before my time as a legislator. There was something that happened then about a change in how we manage these things.
As the board will allow, Gwen Dayton with the Oregon Medical Association, the peer program went away a couple of years ago, in large part because the medical board was not referring people to it. And it wasn't sustainable in its current form. We look forward to working with you and putting together, in fact, we're actively working on a new physician wellness program, but it needs to be built on a more sustainable model, because we weren't getting referrals from the board that allowed it to continue.
I think that's a point of contention. I, from my experience, don't agree with that.
Well, we need to partner with OMB.
But I want a little more clarity on that. Was the peer program for impaired physicians, or was it for
Physician Education and Evaluation Remediation Program is what the acronym stands for. So it's not impaired physicians necessarily. It may be physicians
Right.
those with clinical shortcomings. But it's an opportunity among many, I think, to help improve our process of bringing physicians back into safe practice. And we could have a long conversation about the resources that we need to get that going.
I see this as two different things. I want to make sure I'm clear on this.
Yeah.
We have impaired physicians who, I should also give you a little more background, I suppose. I spent 4 years as chief of medicine at Rogue Valley and Providence Hospitals where I practice. And trust me, I've had 3 a.m. phone calls from local bars, so I know what happens. Okay, I'm not completely naive. So impaired physician to me is someone who has an emotional, medical, or drug problem. The people I'm really talking about are what they're doing in their practice. They're not significantly impaired in any way. I think we all have personality disorders, or we wouldn't be doctors. So that's just me. Okay, but. What I'm really getting to here, trying to, is physicians who apparently are not impaired in any way, but who need more education about their practices. And I'll go again to opiates. If you didn't know, you're supposed to be doing 3 things every time you see an impaired patient and documenting it. That kind of stuff is something that's educational. Is that what peer groups might be doing, something of that nature?
Yes.
Okay, thank you.
Could I just...
Yes, please.
I just want to be clear about something. Dr. Girard, I mentioned in my comments, we don't have a numerator and a denominator here. So what we are presenting is anecdotal evidence. We understand that these are not hard data that will tell us a complete picture. But as I said at the beginning of my comments, the level of background noise has increased to the point where it's come to the attention of Senator Bates and myself, and that's why we wanted to have this conversation. And there is no doubt in our minds that we want to make sure that we don't have bad doctors practicing in our state. We are completely committed to that. And I also believe you and Dr. Williamson and Mr. Kopetsky when you say that you have seen this board function very, very well and with the right intentions. I think our biggest concern, and one of the reasons we're really trying to have this conversation, is obviously we don't want, when we talk about discretion, we talk about it in two ways, right? We want to respect people's privacy, that kind of discretion, but we also, we don't want to have mandatory minimum sentencing, right, in the medical community the way we have in the courts. And we want to be sure that individuals are treated as individuals and helped or treated in the most appropriate ways. So those two kinds of discretion are very important, but in combination with a transparency and a consistency of process, a transparency about the process, a transparency about what's happening and when, and a transparency about how decisions are being made so that people know what to expect. And that's also been a recurring theme. I believe the intentions of the members of this board are very, very good and are exactly as the three of you have described. I think Dr. Bates, Senator Bates, whichever role we're here in, my buddy Alan over here, we've worked together a long time, long before I was a legislator, and I believe the intentions are exactly as you've described them. The question is, are those intentions being followed consistently? And are the interactions that investigators, staff members, you are not on the front lines every single day interacting with doctors about whom complaints have been filed. And I am not here to criticize your staff at all. I'm just talking, I think we're talking about culture. We're talking about transparency. We're talking about consistency. Those are the kinds of things that we're eager to have this conversation about.
Let's talk more about that. Dr. Yates.
Good afternoon, senators, doctors. Thank you for being here. I had a couple comments. First, I'm a branch medical director at the Portland Clinic and a full-time family physician. I deal with physicians all day long. I sit in peer review. I counsel, literally on a daily basis, the colleagues coming up from below me. I'm also chairman of the National Research Foundation for the American Diabetes Association. I'm finishing my 4th year there. And I was a 4-time elected public official at Mount Community College, you may or may not know. Now off that board for appropriate reasons, I think. So I understand the political process, and I understand what you're hearing. So I want to just comment on a couple things. First of all, number one, we are all colleagues. I'm impressed. That fact is impressed upon me every IC meeting, every quarterly meeting. We listen to what one another have to say about these cases. And just so you know, a typical flash drive, when you sit on a monthly IC meeting, some months we have 2 meetings, we spend upwards of several dozen hours getting ready. A flash drive is typically around 6,000-7,000 pages, and we read those pages. Rehabilitation. When I first came on, because that came up first and foremost, one of your first and foremost comments. When I first came on the board, I was put in charge of trying to come up with a process of increasing collaboration with HPP, and we did. And we actually got that process moving, and then, of course, it was taken away from us, sadly. But we believe in rehabilitation, and we want to see that process move forward. It is first and foremost contrary to what you've been told. So you posed this as a problem in the last 3 to 4 years, and there's something I think I should share with you, because I've been on the board before the last 3 to 4 years. There has been a change. Let me tell you what I think that change is. It's this economy. We are seeing cases of individuals coming before us doing things, frankly, they should not do. Whether it's getting into areas of aesthetic medicine with injections and procedures, much of this, a lot of it that I've seen, is often driven by economics. maybe taking care of patients they shouldn't be taking care of, hanging on to people they shouldn't hang on to, when they should have referred them earlier, getting themselves into situations that I think prior to this economic downturn probably was not happening, or people coming back into practice that had previously been retired because they're feeling the economics of the situation. They're not going to tell you this. We see it in the charts. Again, we're clinicians. What I would propose to you is two things. Let's look at the data together. Everything you're describing at this point is anecdotal, and as all of us know, that's the worst possible data to go off. So let's look at the data. The data's there. Let's have the staff generate numbers for you. And secondly, when you get a complaint, call us. Because you're public officials, we can discuss the specifics of this complaint. Right now, you've been getting a one-way conversation. You're not being told much of what's going on and what preceded this. And then lastly, I said two things or three things. Come to an IC for even an hour. Watch what we do. Listen to the deliberation. See for yourself the level of preparation of the people that are here to understand that we're trying to do this in a fair and equitable way. And on that last comment about consistency, of course there's inconsistency because it's going to depend on what the individual tells us. It's going to depend on their sincerity. It's going to depend on what preceded in terms of how many other cases they've had and so on. And I would also say a lot of this is driven by, has there been a fatality? In terms of some of these cases with overdoses, we're seeing fatalities, and not just one in the case of some of these individuals who come before us. So those would be my only comments. Let's start a process of dialogue, but let's base it around outcome data. Let's look at the data together. And when you get specifics, come to us so we can discuss them.
May I offer, I know Dr. White's been waiting. May I offer a comment in response to Dr. Yates? I want to be very clear, and I think it's safe to say that I'm speaking for both of us. We understand, I've said this 3 times, that this is anecdotal. And I appreciate your offer to look at data with us, and I think we have every intention of taking you up on that offer. We are not here to attack. And I'm starting to feel, perhaps inappropriately, perhaps I'm overreading, but I'm starting to feel a lot of defensiveness, and that wasn't our intention to induce that. Our intention was really to have an open conversation in a mutually constructive way. Dr. Bates said, and I agree with him, that several of the complaints we've heard we think are unfounded. We think that the people are being whiny and petty and not owning up to their problems. But other times that's not the case. And so we wouldn't be here. I mean, we're doctors too. We believe in evidence, and we're thoughtful, careful people who care deeply about the health of our state. So I guess I just want to be clear with you that we wouldn't be wasting your time or ours if we didn't think that there was enough reason to have a conversation, enough complaints that we heard that made us worried. And the kind of inconsistency you talk about is exactly what we're talking about when we talk about discretion. That's great. We appreciate that. And that's not inconsistency. That's tailoring the response to the situation, and that's exactly what we think should be happening. We really are very eager to start a process here and to make the overall process better for everybody and to continue to fulfill the mission of the board. So I just want to be really crystal clear about that.
That's a great message.
And I as well was not being critical.
Well, an open mind and embracing suggestions and feedback is the only way an organization can improve. Spot on. That's Dr. White. I'm sorry, you've had your hand up. Sorry, Dr. White.
Just to say, I'm sorry, Dr. White. I want to respond, Ralph, to one of your suggestions. I don't think we're going to have enough information to be anything but anecdotal. I'm sorry, unless you got 10,000 cases, which hope to God you don't. But your suggestion was that we have a complaint that we think that maybe things didn't go as well as they could have. We should bring that case to you individually. I think that's a great idea. And if we could, we have to get the okay from the practitioner involved. But we could come to you with a specific case that we have a concern about after looking at it ourselves a little bit, and have a conversation. But I think that's really a dialogue that would be meaningful for both parties. And I think it's a great suggestion. I'm putting that in my punch list here, okay? So thank you for that suggestion. I think that would make more sense than anything else. We can sort of talk in the general and never get down to anything serious that would really help. So thank you for that suggestion. I'm going to put that one
I
down.
would just add one thing, and I'm really sorry,
okay.
Keith. I agree, and I'd love to be able to come to you with specifics. We had the opportunity to meet with several physicians in person who had concerns, one of whom we all personally think was completely unfounded. He was being whiny. The other two of whom we thought perhaps had legitimate concerns. But it took a long time to find physicians who were even willing to talk to us. Because, as I mentioned in my very introductory remarks, there's a climate of fear right now. And the concern among physicians that if they talk to us and then we talk to you, that there will then be retribution in the handling of those cases. I understand that may be completely irrational fear, not based on fact. I'm giving that information as an example of what we're trying to overcome together with you in terms of how the board is perceived. Because there should be the opportunity to have that kind of dialogue. There should be the opportunity for people to come to us and us to come to you and us to have an open conversation without them being terrified that things will go from bad to worse. And so that's why I think it's great, and we just need to figure out a way to make it happen in ways that doctors aren't afraid to do that.
I think you can accomplish that goal without identifying specifics of a case that might threaten those and make them feel less likely to bring information to your attention. We need to have information that can be de-identified if necessary, but to act on it, that's a great opportunity for us.
I'd like to... I'm a family practice doctor in a small town, but I use the biggest hospital in Oregon. So I've been involved in a lot of administrative work in the medical staff in that big hospital. I'd like to say that I've been associated with the board since 1996, first as a consultant, now as a board member since 2009. And I'm very impressed by the degrees to which this body goes to try and rehabilitate people. The comment you've made about perhaps there's some unevenness and inconsistency. Well, it may look that way on the outside if you can see the original complaint, but it kind of brings to mind that old joke about how many psychiatrists does it take to change a light bulb? Only one, but the light bulb has to want to change. Well, how many board members and board actions does it take to change a physician? Well, a physician has to want to change, and so sometimes when you see some inconsistency in results, it really has a lot to do with the way that the physician, whether or not the physician can gain insight into what is a legitimate and agreed upon, consulted upon a problem they may have in practice. I'm talking about the not so much the impaired physician, but people with the actual elements of their medical knowledge and practice. We have some extremely good physicians who are honored physicians who have some blind spots. And that there's a recent case of a physician in my specialty who I actually know who really committed some fairly egregious and obvious mistakes that even a person who's never been to a drug course should have known better than. Okay? And so maybe you've gotten some contact and complaints from there, but it was pretty clear to all of us that there were some serious mistakes made, and some knowledge had to be gained. And I'd say that the board holds people to some fairly reasonable standards that don't include going through that checklist of 10 things every patient visit. And so I don't feel like the board is holding people to unreachable standards. The board would like people to use good practice standards, and they've published it. There needs to be more education. The fact is that most of us, Dr. Bates, I don't know how old you are, I'm 62, were educated at a time when it was forbidden to use opiates on patients who were not dying from cancer. And I can recall going to an OMB meeting and seeing some of my older colleagues there who were being remediated while I was just trying to gain some information, because I'm sure that they had used opiates in people who perhaps weren't dying from cancer. And the pendulum has swung, of course, 180 degrees now, and none of us were educated properly. And it's a whole specialty field that we were not educated properly, and so we're struggling every day to catch up and learn what we need to do. I struggle every day with the chronic pain patients. So just wanted you to know that I think that it would be great for you to be able to discuss specific cases where you have complaints, and perhaps some positive light can come from also from changes in process if necessary.
Thanks. I think Dr. McKimmey wanted to say something.
Thank you. Senator Steiner-Hayward and Senator Bates, thank you both for coming today. And I realize that bringing your concerns to the board is not something you necessarily enjoy doing. And with your introductory comments, I will confess I felt my defensiveness rising a little bit too, and I don't think that's the timbre we want to set for this discussion at all. My reaction to your introductory comments, both of you, was much like Dr. Girard's. Stunned is too strong a word, but taken aback, perhaps. And I think it's difficult for any individual or any body to step back and take a look at what it is that we're doing and say, okay, are we really going to be open to constructive criticism? And I want to assure the two of you we will be, speaking as vice chair of the board. And if I may paraphrase what I've heard so far, I think you want the board to be aware of how we interact with the physicians of the state who are under investigation, and that to the extent that we can engage them in the process and not make them feeling like they're dealing with the KGB, that perhaps that will be contributing to more successful outcomes. Am I right about that?
Yes.
Okay. And at the same time, I'm sure you realize, and you've already told us this a couple of times, that sometimes the information you get is heavily filtered by the information you have access to. And I will only we work so hard at what we do that it would make us feel great if either of you or another member of the legislature wanted to join us for my committee, which is the disciplinary arm of the state board, which is the investigative committee. We would love to have you for any proceeding that you care to join. Just a brief glimpse, if you will, and I can speak for myself, my motivations for being here. I was an office holder in the Oregon Medical Association for 8 years prior to